Achalasia and esophageal dysmotility. Etiology, pathophysiology, and pathology. The cause of disordered esophageal motility is generally unknown. Achalasia is the most severe form, characterized by a hypertensive lower esophageal sphincter, LOES, with failure of LOES relaxation in response to swallowing. Peristalsis is absent in the body of the esophagus, which becomes progressively dilated. Histological examination reveals loss of myenteric plexus ganglia. Epidemiology. Achalasia is rare, with an approximate incidence of 1 in 100,000 in the West. Less severe forms of esophageal dysmotility may be more widespread and may account for some cases of apparent gastroesophageal reflux disease without documented acid reflux or response to acid suppressive treatment. Clinical presentation. Common dysphagia, difficulty in swallowing, and odynophagia, painful swallowing, are typical. Regurgitation may cause nocturnal cough and respiratory complications in achalasia. Physical signs. Often absent, but weight loss may be evident. Investigation and staging. Barium or gastrograph in swallow. This should be performed before endoscopy, showing food debris in the esophagus with dilatation in later stages and a smooth, tapered bird's beak at the distal end, Fig 26. NB. Gastroscopy should always be performed to exclude malignancy at the gastroesophageal junction. This can mimic achalasia, particularly in elderly people. Manometry. The typical pattern of progressive peristaltic contraction waves in the esophagus in response to swallowing is lost. There may be diffuse spasm, diffuse esophageal spasm, or intense prolonged contractions, nutcracker esophagus. In achalasia, the body of the esophagus fails to contract peristaltically and there is increased pressure at the LOES, which fails to relax in response to swallowing. Differential diagnosis. The pain-associated WTH esophageal dysmotility may mimic cardiac or pleuritic chest pain. Chagas disease, caused by South American trypanosomal infection, is rare but may present with identical clinical, endoscopic, and radiological features to achalasia. Treatment. Medical explanation and reassurance are essential. Prokinetic agents such as metoclopramide may provide some symptomatic relief. Calcium antagonists, e.g. nifedipine 10 mg TDS, or nitrates, e.g. isosorbide, can be tried, but response is variable. It is pragmatic to offer a proton pump inhibitor to minimize any effect of gastroesophageal reflux. Endoscopic and surgical treatments should be explored if achalasia progresses to cause dysphagia and regurgitation. Pneumatic, balloon, dilatation or surgical myotomy, Hellers. Results are comparable, with 75–85% having excellent relief of their symptoms. Perforation occurs in 1–5% after dilatation. Late stricture formation occurs in about 3% of surgically treated patients. Intrasphincteric injection of botulinum toxin. This is as effective as pneumatic dilatation at 4 weeks but not at 6 months, when repeat injection is often required. Complications. Common. Risk of esophageal carcinoma is increased about 15-fold in patients with achalasia. Reflux esophagitis and stricture formation, less than 1%, may occur after pneumatic dilatation. Prognosis. Over 90% of patients with achalasia are improved following pneumatic dilatation or surgical myotomy. Repeat dilatation is frequently required.